All right, well, welcome. We are delighted to have another iteration of Medical Grand Rounds. And to introduce today's speaker, we have Dr. Sanjay Asthana, our Division Chief of Geriatrics and Gerontology.
Thank you, Dr. Schnapp. Good morning, everyone. I'm Sanjay Asthana, head of the Division of Geriatrics and Gerontology in our department. It truly is a pleasure and frankly a privilege to introduce and then invite Dr. Neil Binkley to present today's Medical Grand Rounds. Dr. Binkley is Professor of Medicine in the Division of Geriatrics and Gerontology. He's internationally renowned for his expertise in the area of bone mineral disease, metabolism diseases, and also sarcopenia. Dr. Binkley received his MD from our own medical school right here at UW-Madison. Then he went to Marshfield Clinic to do his internal medicine residency. After his residency, Dr. Binkley decided to go into practice. So he did private practice in Hayward and Marinette areas of Wisconsin. After being there for almost 7 years, he decided that academics was the place for him to go into. So he came back to UW-Madison as a geriatric fellow. He did his geriatric fellowship, which in those years was 2 years, completed his 2 years geriatric fellowship, and then decided to do additional year of research fellowship. And Dr. Binkley was one of the first fellows appointed to the Biology of Aging T32 training grant here in our department, which has been funded for over 31 years. So he's one of the first few leaders that came out of that training grant. Dr. Binkley also, he joined the Division of Geriatrics as a faculty in 1992 and has been our faculty here for over 30 years. He has multiple local and national leadership roles in osteoporosis and related diseases. He presently is director of the UW Osteoporosis Clinical Research Program. He has been in that position since 1993. And he's also associate director of the UW Institute on Aging since 2002. He's a recipient of many honors and awards, and just to name a couple of them, he is a fellow of the American Society for Bone and Mineral Research. He is recipient of the Paul Miller Service Award from the International Society of Clinical Densitometry, and he's received another award from that society. Dr. Binkley is on multiple editorial boards, including the renowned Journal of Bone and Mineral Metabolism Research, Journal of Clinical Densitometry, and International Osteoporosis. Dr. Binkley is one of the most published scientists in the area of osteoporosis. As of today, he has published 343 papers, 22 book chapters, and 577 published abstracts. And I think this just speaks of his status and the authority in the area of bone mineral disease. It is a pleasure to invite Dr. Binkley to make his presentation entitled Osteoporosis, a Legacy of Failure and Proposals for Success. Dr. Binkley.
I think we got this, Sanjay. Thank you. Well, I appreciate the opportunity to share some thoughts with you today. And I'm going to share with you the data or some data that says, by golly, we have failed. I'm going to suggest maybe why we have failed, and then share with you some opinions and thoughts about how we maybe could do better. And we need to be doing better. And the reason that we need to be doing better is that fractures threaten our patients' independence. And so that's basically where we're heading today. These are my disclosures. The disclosure that I think is important is in the orange box. And that is that some of this is my opinion. And rather than telling you that it's my opinion every time I share with you my opinion, it's going to be this orange text color. So here's where I hope we're going to go. I think we're going to discuss the osteoporosis treatment gap, explain part of the problem, which is what in blazes is osteoporosis. So we have various definitions out there that I think are confusing people. I'm going to suggest to you that we should get rid of the word fragility and we should take a syndrome approach to preventing fractures and then summarize what I believe to be a reasonable approach to osteoporosis evaluation and to briefly calcium and vitamin D nutrition, and then apply a common sense approach to fracture risk reduction that was developed by myself in concert with 3 of my colleagues in the osteoporosis clinic. So let's start with the treatment gap and ask, why are we treating osteoporosis? And the reason is obvious, that fracture is what's important. Osteoporosis in the absence of fracture is asymptomatic. So we need to be preventing, and then once fractures occur, we need to be doing something to reduce people's fracture risk. And we have been failing. Here's a couple of publications now from a few years ago. This is one documenting, where's the pointer? Documenting the decline in osteoporosis treatment from 2002 to 2011. This was published by Dan Solomon, and the accompanying editorial by John Canis, who's the architect of FRAX, says this here: this is, the treatment gap is scandalous. I believe it's the only time I've ever seen the word scandalous used in the medical literature. And here was an editorial by Sandeep Khoshla and Elizabeth Shane, 2 past presidents of ASBMR, that basically says this is inconceivable. What we're doing after people sustain a bone attack, i.e. a fracture, is nothing. And after they sustain an MI, a heart attack, we do something. And this just isn't the United States. This is a worldwide phenomenon. Here's a recent publication from Eugene McCluskey in Osteoporosis International. They defined the treatment gap as you see here. These are people at high risk but are not treated, and looked at 8 European countries. The best country was Ireland, where they were treating less than half of people at high risk. The worst in this paper was Germany, where they were treating less than 1 in 10. Lest you think we are doing a better job here in the States, here's a publication from patients in Virginia seen in a US emergency department, about 3,000 of them, pardon me, with acute vertebral fracture. In the 2 years before or the 1 year after they sustained their fracture, 2% of them had their bone density measured, 7% of them received treatment, and from 2008 to 2014, the treatment rates declined. And when we do nothing, people refracture. So fracture tells us who's going to break. And so these are the patients, roughly 3,000, who presented with acute vertebral fracture. In the next 2 years, 4 out of 10 of them had another fracture. So fracture is the salient event. It tells us that these folks are at high risk. And importantly, this matters. So this is the number that's often trotted out as this mortality of 20% higher in men. But perhaps of more importance is loss of independence. And after a hip fracture, this is profound, where 40% of survivors are unable to walk independently, 60% require assistance, and 1/3 go into the nursing home. And perhaps it's easier to talk about when you get gray hair, but it's fairly easy for me to talk to patients and say, hey, look, going to the nursing home is not an improvement in quality of life. So this is what matters. And indeed, there are surveys out there, this one from a number of years ago, where roughly 900 people were asked, what are your concerns about aging? Loss of independence was the bigger one, and loss of mobility, which is another way of saying loss of independence. This was 2/3 of the biggest concerns. And so I believe that maintaining independence is really the reason to treat fractures and to prevent fractures. So, well, that's sort of a broad overview that says we're not doing very good. We must be doing better here in Wisconsin. And here is the Milliman report that was commissioned by the US National Osteoporosis Foundation. It was published in the spring of 2021. And very briefly, they used Medicare claims data And in 2016, there were roughly 38,000 fractures among Wisconsin Medicare beneficiaries. That translates to 1 in 5 women on Medicare break every year. This is not good. Costs a bunch of money, 83 million in Wisconsin. The one-year mortality was even higher, 30% after hip fracture, 20% after any fracture, and 8% of these folks who had a fracture had their bone density measured within 6 months after the fracture. That's exactly the same rate as the country in general. If you happen to be Black, it's 5%. If you happen to be Native American, it's 2.5%. Not good. Well, how about here at UW? We must be doing better. And these data are not published, but we took a cut through this a few years ago from 2008 to 2014. 845 adults with primary care providers within UW who sustained a hip, vert, or wrist fracture, and 16% of them had a DEXA. I don't have the treatment data. And so we're twice as good as Wisconsin, but we're still treating less than 1 in 5. So it's pretty hard to say that this is anything other than the field that I've spent the last 30 years in has not been succeeding. We've been failing our patients. And I love quotes, and I found this one from Einstein that says that failure is success in progress. So how can we have success in progress? And I think that I'd like to start by discussing what in blazes is osteoporosis. And there are multiple definitions out there, and they're not the same. You can have an anatomic definition, a T-score definition, a fracture definition, or an elevated fracture risk definition. What are we talking about? Well, I think this is really what osteoporosis is, and this is an old NIH consensus conference definition, but I think they got it right back in 1991. And they says it's a systemic skeletal disease of low bone mass and microarchitectural deterioration leading to susceptibility of fracture. And looking at these scanning electron micrographs, you do not need to be a bioengineer to know that this structure is not as strong as that structure. So that's really what osteoporosis is, but how does that help us in the clinic? It really doesn't. And so to help move the field forward back in 1994, the World Health Organization operationally defined osteoporosis based upon T-score. And you're all familiar with this classification, -1 down to -2.5 being osteopenia, worse than that, osteoporosis. How did they come up with that? They used the Goldilocks principle. Not too hot, not too cold. And they said, well, if we choose 2.5, that identifies about 1/3 of women who are going to have osteoporosis, and that's about the number who are going to break. It wasn't that this was any sort of brought the tablets down from the mountain. This was, it feels right. But nonetheless, we've married that, and that's okay. But we can't just use that to identify who's going to break. And so these are old data from the Rotterdam study, and they've been replicated in multiple other studies. And what it says is if we just treat individuals with T-score osteoporosis, we treat less than half of women who will sustain non-vertebral fractures and 20% of men. So we can't just say T-score equals osteoporosis equals need for therapy. And because of that, there have been other definitions brought forward. And here's one that says fracture equals osteoporosis. So if your patient has sustained a low trauma fracture defined here as a fall from standing height or lower, you can diagnose osteoporosis. Well, wait a minute. Isn't that overdiagnosing? No, it's not. So we looked at that with Bill Leslie in the Manitoba DEXA registry, and we defined normal bone as normal bone density and normal trabecular bone score, and then looked at this cohort of roughly 2,500 women who sustained an incident fracture. And how many of them had truly normal bone? Practically none. So if you have sustained a fracture, that indicates that your bone, in fact, is not normal. I mentioned trabecular bone score. What in blazes is that? You're seeing that on all of the DEXA reports, or most of the DEXA reports from UW. I'm not going to go into it in any detail, but basically this is a texture analysis that's done on the DEXA scans, and it speaks to loss of bone microarchitecture. And the easiest way that I've found to explain it is to ask you to pretend that you're flying over the northern Wisconsin forest. And if the trees are homogeneous, that you have normal tree texture, that is the analogy to normal bone. And if the loggers have been in here cutting down trees, that's the analogy to loss of bone microarchitecture. And we're using that to adjust fracture risk. And indeed, you can also diagnose osteoporosis by elevated fracture risk as estimated by the FRAX tool. FRAX is the most widely utilized tool on the planet. This was from the National Bone Health Alliance a number of years ago, and they recommend that you diagnose osteoporosis if people have an elevated risk for future fracture by FRAX. And so I think that a step forward, and this is my opinion, that we should be not just diagnosing osteoporosis by T-score, but rather we should be diagnosing clinical osteoporosis as a T-score less than a -2.5, or a prior fracture, or an elevated fracture risk. So at least we understand what we're talking about when we say the words osteoporosis. And then what are we going to do about it? Well, I think that we should be saying, let's not use the word fragility, and let's think about this as a syndrome rather than just a bone problem. And I'd like to ask, why is it that we're not doing better? And it's my bias that we have too many guidelines. So in preparation for this, I went to guidelines.gov a month or so ago and entered osteoporosis treatment and was rewarded with 531 guidelines. These are not in agreement. How can a clinician not be confused when he or she has 531 watches? We need to harmonize guidelines. And indeed, there has been a fledgling effort that was led by Mike Lewicki towards guideline harmonization. This was basically some people sitting around a table at one of the bone meetings where we said, can we come up with any sort of general agreement from Mexico, Canada, and the United States? And so this is published. I think more needs to be encouraged. I'm not going to go through the points in detail. And about 6 years ago, at roughly the same time, a number of us published this editorial that says, how about some proposals for progress? What can we do to move forward? And the first I've alluded to is, let's not be focusing on osteoporosis, let's focus on fracture. Don't be afraid to say the words quality of life and independence. Our field hasn't done that. Get rid of the word fragility because our patients don't believe it, and encourage that all fractures in adults need to be evaluated, and recognize that what we have historically called osteoporosis is just part of a syndrome that leads to fracture, and address all components of the syndrome. And it was actually rewarding to see this recommendation from what used to be the US National Osteoporosis Foundation. About a year ago, they changed the name to BHOF, the Bone Health and Osteoporosis Foundation. And just this fall, they brought forward their 2022 update. And their first universal recommendation that they led the paper with was counsel patients on the consequences of fracture, including loss of independence. We've never said that before. And secondly, investigate any broken bone in adulthood, regardless of cause. So it's my bias that this is really a step forward, and doing so, thinking about all fractures, gets around this argument. Doc, anybody would have broke if they fell like I did. You would have fractured if they fell like I did. If I had a nickel for every time I have heard that, I would have a mansion in the Bahamas. So getting around that says, okay, you might be right, but let's find out if we should be doing something to prevent another and preserve your quality of life. Fragility fracture is not something that resonates. There's a little bit of literature out there. And this is just a quote from one of these papers that says, we have demonstrated that there appears to be nothing fragile about a fragility fracture based on our patient's perception. So use the word broken bone. You broke a bone, let's see if we should be doing anything. It's my bias that osteoporosis treatment guidelines too often have focused just on drugs. And here's a nice example of that from the Endocrine Society. Pharmacologic management of osteoporosis. So I think a treatment gap is thinking that treatment equals a bone drug. And that just doesn't work. And so here's data from a head-to-head trial of probably two of our best medications, abaloparatide and teriparatide. And what you see here is that these bone anabolics dramatically reduce vertebral fractures, but not non-vertebral fractures. Only about a third, half of non-vert fractures are prevented by these. And well, maybe, is it just those two drugs? No, it's not. So here's the non-vert fracture risk reduction. And these aren't head-to-head trials, so you can't conclude one drug's better than the other, but the non-vertebral fracture risk reduction is not very good. So it's not just prescribing a bone drug. And why is this the case? Oversimplifications are always wrong, but my overly simplistic approach to this is that bone drugs don't prevent falls. So as of today, we don't have a medication that improves your bone status and also reduces your risk for falling down. And it's the falls that cause us to break. And in that regard, I believe that we should learn from others and consider the heart attack or the myocardial infarction analogy. And you're all familiar with metabolic syndrome. Too much fat, too much blood pressure, too much sugar, and too much weight. That in concert with advancing age, family history, toxins leads to MI and reduced quality of life. A number of years ago, we proposed that the same holds for musculoskeletal status, and we called it dysmobility, as difficulty walking. I don't care what word we use, whether we use the fracture risk syndrome or whatever. But this is obesity, diabetes, not enough bone, and importantly, not enough muscle. Not enough muscle mass, not enough muscle function, identified as sarcopenia. We have not been successful at getting sarcopenia to the clinic. But that then, thinking about sarcopenia and balance and strength leads logically to non-pharmacologic and potentially pharmacologic approaches to reduce falls risk. And it's my bias that if we're just treating osteoporosis with bone agents without considering these other parts of the syndrome, it's like treating hyperlipidemia and ignoring hypertension and diabetes in patients with metabolic syndrome. You wouldn't expect to get optimal outcomes doing that. We shouldn't expect optimal outcomes if all we do is treat the bones. So let's think about a rational approach. And I'm going to go through this very quickly because I think this is something that is fairly straightforward. So what do? Well, we take a history and physical. We think about the bones, starting with DEXA. Vertebral fracture assessment is looking for occult or unappreciated vertebral fractures, and about 2 out of 3 vert fractures are not appreciated by the patient. I've mentioned trabecular bone score. I'm not going to go into opportunistic CT in detail this morning, but it's a wonderful tool, and many of our patients have CT scans of the chest or abdomen on which we can perform Hounsfield units at L1 and speak to their bone status. Then consider causes of bone loss, do a lab evaluation, falls risk, falls risk, falls risk, and finally assess fracture risk and use bone drugs if the fracture risk is high. So I mentioned that it's asymptomatic. Think about risk factors, recognize sarcopenia. Do they have a history of hyperpara or nephrolithiasis? Ask about prior fracture. Prior fracture tells us who's going to break. And I mentioned that it's important to do VFA to identify occult vertebral fractures. This list is deliberately too small. It basically is out there to say there's a whole bunch of things to think about, and there's all kinds of lists available. This is one from the recent BHOF publication. If you want to go and think about the drugs and all the other conditions, there's a nice new list. Do the physical. Think about height measurement. And I'd encourage you in your clinic to try to improve height measurement. I know when I go in to see various physicians, sometimes I get asked how tall I am. Be assured that's not correct. And this was actually looked at by Anthony McCullough. He was a med student here 6 years ago now. And he did two things. One, he went to clinics and looked at how people were measuring height. And virtually in every clinic, it was being done wrong. And then he looked at almost 5,000 UW patients with no known bone disease in the EMR and said, how often did their height change within 3 months by more than an inch? Well, guess what? Our height doesn't change by an inch in 3 months, 18%. So we need to be improving our height measurement because height loss can be a measure of vertebral fracture. And then think about orthostasis that causes us to fall over. Think about other things like osteogenesis imperfecta. If we have cataracts, we can't see the steps, so we trip on the steps. Gait abnormalities, muscle weakness, neurologic and balance issues. I think that the simplest thing to do as part of a physical exam that speaks to what is probably sarcopenia is to ask our patients to stand up. So they're sitting in a chair. If you're sitting in a chair and you can't, and you have normal muscle function, you stand up. If you have sarcopenia, you put your elbows on your knees and you push and you stand up like this. And so when you see that, that's basically one synapse to say, let's get physical therapy involved. The lab evaluation, again here from BHOF, think about chemistries, PTHD, and all this other stuff depending on the patient. And so after that, then start with non-pharmacologic stuff and optimize nutrition. It's easy, it's safe, it's cheap. However, it's chaos. Bone health nutrition, in my biased view, is really in chaos. I don't think anybody can stand up in front of the room and say, I know the right answer. But what follows is my opinion and my personal approach. And that starts with this, what I believe was a landmark publication by Robert Haney. Professor Haney was down at the research program, the bone research program in Omaha, godfather of osteoporosis nutrition. And he published this paper that basically told us how we should be doing nutritional trials. He also commented at about the same time that flawed trials can't be meta-analyzed away. And this was 10 years ago. Bob said that the question of how much vitamin D is going to be muddled as long as we don't think about biology, and he was certainly right. And basically what he told us was that nutrients aren't drugs. And think about this sigmoid curve. So if our patient is low in nutrient X, be that calcium, be it vitamin D, be it whatever, giving more of that nutrient is going to have a benefit. If they're replete in a nutrient, giving more will produce a null effect. And if they're high, the only thing that you can do is cause toxicity. And Bob would have never said, duh, but that's what he said here. This is so obvious from simple inspection of the curve that one should have thought it would go without saying, but it hasn't. And here's a paper from this year in the New England Journal of Medicine. And the authors, this is the VITAL trial, huge trial. The authors of this paper actually, I believe, did a really pretty darn good job. And what they concluded was that D supplementation did not result in a lower fracture risk than placebo in generally healthy folks who were not selected to have vitamin D and deficiency and not selected to have low bone mass. I think that's what one would predict. And in fact, their average 25-hydroxy-D at baseline was 30 nanograms per mil. And I can hear Bob Haney in the background saying, if the nutritional status is replete, an increase will produce a null effect. And it did. But then there was this editorial published in the same issue of the New England Journal by highly respected people in the field that basically said no subgroups benefited. And then providers should stop measuring 25D, stop measuring D, stop recommending D supplements, and people should stop taking them. Well, is it true that we were powered to say that no subgroups benefited? And the short answer is no. So in VITAL, they had about 400 people who did indeed have vitamin D deficiency, and they followed them, and I'm not going to go through all the data here, but the gist of it is that they had 7 fractures in the vitamin D group and 8 in the placebo. And so there wasn't a benefit. And then I said, well, are there any osteoporosis trials that studied 400 patients? And yes, there was. This one by Nelson Watts in 1990, they studied 423 exceptionally osteoporotic women. At the time, they used a Z-score of -2.7. They demanded vertebral fractures, so this was an incredibly high-risk population. And then they gave them cyclic etidronate. And what they found is that 6 fractures occurred in the etidronate group and 3 in the placebo group. And if you believe you can get data out of 400 people, you would conclude that bisphosphonates double the fracture risk. So this is clearly underpowered. And so it's my bias that you can't demonstrate a fracture risk reduction in 400 folks. And VITAL, I think, rather than providing the definitive description about vitamin D, I think it does decisively prove that vitamin D is a vitamin. It's not a bone active drug. And the fracture data are, in my opinion, inconclusive. I don't believe we should alter our care of patients with low bone density or prior fracture at all in regards to vitamin D based upon the VITAL trial. And finally, I want to remind you of studies like this. And again, going back to Haney, who said that if you've got enough, if you've got enough vitamin D or any nutrient, the only thing you can do by giving more is cause toxicity. And here's this nice study out of Canada where all of the folks were vitamin D replete. The average of these 325-hydroxy-D levels was about 30. But nonetheless, they gave them 400, 4,000, or 10,000 IUs and did high-res PQCT of the radius, and they showed that the higher dose group lost more bone. This makes sense. It probably is due to increased bone remodeling. But all you can do if you've got vitamin D replete folks and give them more is cause toxicity. So I think that you can't meta-analyze fatally flawed trials and get reasonable conclusions. And so when the evidence is flawed, we're stuck clinically applying common sense. And my view of common sense is that you and I are not much different than these folks, the hunter-gatherers. And this has been advocated for years that the nutritional requirements of these folks are probably the nutritional requirements for us. People have estimated the hunter-gatherer calcium intake at about 1,600 milligrams per day, very comparable to the BHOF recommendation of 1,000 and 1,200 milligrams. Well, but how about calcium supplements and vascular disease? And there are some data out there that suggest maybe that's the case. This was a publication from the NOF and one of the preventive cardiology societies that basically says, yeah, we don't think it's anything there. But remember, these are flawed trials. And this is maybe reassuring. I personally find it at least plausible that if you give somebody who's already got enough calcium in their diet, more calcium, you might cause problems because the only thing you can do is cause toxicity. So if our patients are getting enough calcium from their diet, we don't need to be recommending more. Common sense for vitamin D. is we were designed to live outdoors. We were designed to make vitamin D. This was the most fun research study I ever did. We went out to Hawaii and recruited surfers. It was tough, but somebody had to do it. Using a standardized assay, these folks came in at about 36 nanograms per mil. This was a wonderful study where Luxwolda and others went into sub-Saharan Africa and found the last few hunter-gatherers on the planet, and they came in at 46 nanograms per mil. So it looks to me like humans were designed to run somewhere around 40 nanograms per mil, and I think that makes sense to aim for that. Be aware that this often requires 1,000 to 2,000 units to get to those levels. Importantly, recognize that our labs are imperfect. This is true for everything. All our quantitative tests are done by a human being using an instrument. They both have variability. The vitamin D standardization programs recommend that our 25-hydroxy-D assays perform with a CV of less than 10%. What does that mean? It means that if you receive a clinical value for your patient of 30 nanograms per mil and our lab is performing within 10%, that means it's really somewhere between 36 and 24. So what do you do with that? Well, I think if you're in the camp that believes that 20 nanograms is your target and you get 20 nanograms, recognize that it could be a little higher or a little lower than that. And if you want to be 20, aim a little bit high, so aim for 30. And similarly, if you believe that 30 is the right number, it could be 24, aim for 40. Even if you're on the high side of this, you're not going to get into the toxic range. You're going to be at about 40 or 50 nanograms per mil. This is something that I think I really would like to emphasize because I continue to see it done in Madison, Wisconsin. And that is stop using 50,000 IUs of vitamin D2. If you and I write a prescription for 50,000 units of vitamin D in the United States of America, it will be ergocalciferol. We don't have a prescription dose of D3. You and I make D3 when we're out in the sun. There's probably no need ever to use 50,000 units, or almost never, never say never. But a number of years ago, the UW lab switched from an HPLC assay that differentiated D2 from D3 to an automated immunoassay. And it's probably an impossible ask for the immunoassays to exactly release 25-hydroxy-D2 and 25-hydroxy-D3 from DBP, and then to subsequently measure it. And that is the case here. And so what this is a small study that Don Wiebe from the lab here obtained residual serum samples of patients who had virtually all D3 from low to high, and then virtually all D2 from low to high. And for the D3, the assay was beautiful, spot on. For 25-hydroxy-D2, it recovered about half. So if you've got somebody on high dose D2 and their 25-hydroxy-D level returns low from the automated immunoassays, you don't know if the patient truly is low or if it's an assay problem. Don't prescribe what you can't measure. And finally, I'd like to suggest a common sense approach to fracture risk reduction. So we've done the evaluation. We're going to estimate fracture risk. We're going to consider nutrition. Then we're going to move to exercise and falls risk reduction. And lastly, consider the drugs. I mentioned FRAX. This is the tool that is widely used. It's part of our DEXA reports. You see a FRAX calculation. A FRAX update is imminent. I actually expected it to be out by today. It's not. It's going to be called FRAX Plus. They had just huge patient cohorts, 2.1 million folks, 200,000 fractures. The big things is it's going to include falls, and it's going to include recency of fracture. The closer to a fracture you are, the greater your risk. So you expect to see FRAX Plus soon. And again, think about falls. Falls increase the odds risk for a fracture by about 7-fold in the next year. For perspective, the other things that we think about, advancing age, cognitive impairment, narcotics, et cetera, increase the hazard ratio by less than 2. Falls tell us who's going to break, and therefore we need to try to reduce falls. Here's a brief common sense falls evaluation that I think we actually can do in the clinic. Ask when the last time was that you fell down. Because if you ask, have you fallen? The right answer to that is, of course, no. So give people permission to tell you that they have fallen. Get rid of drugs. One of the first things that when I came back and did my geriatric fellowship here, one of my attendings, when we would admit patients to the hospital, would walk into the room and say, pick any 5 drugs and keep those. I don't care which 5 they are, but keep 5. So reduce medications, and then get our physical therapy colleagues involved. They know how to do this a whole lot better than you and I do. Have them look at gait, have them think about falls reduction, balance training, strengthening. This is where the money's at, is preventing falls. But then we as physicians and providers can recommend exercise. It's my bias that the best exercise program is one that the patient will actually do. I think it's fine for me to tell you to go to the gym and lift weights, and the patient's sitting there thinking, this guy's crazy. Exercise works, but we don't do it. Here's some nice data from the US Bureau of Labor Statistics, looking at the leisure time of retired Americans. Whether you're male in green, female in red, we spend half of our leisure time watching TV. We've got really good thumbs from running the remote. And we spend 5 and 3% of our leisure time exercising. So we have time to do it. We just need to do it. And additionally, we should be recommending Tai Chi. Tai Chi actually works. It's been highly studied. It reduces falls, number of fallers, rate of falls. This is a good thing to do. So to summarize non-drug approaches, I didn't speak to calories and protein. There's only so much you can do in a short period of time. Shoot for 1,000, 1,200 of calcium, 1,000 to 2,000 of D. Measure 25 D in those with fractures. I aim for 40. Reduce falls, as I mentioned. All right, finally, drugs. And here's the most recent BHOF drug treatment guidance. So they say treat if the T-score is -2.5 or worse. But if you're -1.1 to -2.4, then treat if you have an MOF, major osteoporotic fracture risk, greater than or equal to 20%, or if you've had a hip or a vertebral fracture, or other fractures if you have osteopenia. That's the current US guidance. How do the medicines work? Not going to go into the drugs in detail, just concepts. And in this cartoon, here's a bone trabeculum. So we've got these resorption pits here. And what do our anti-resorptive drugs do? They slow osteoclastic activity. They involve filling into the resorption pits. And by filling in these divots, we increase bone strength. Our bone anabolic agents actually grow new bone. It is theoretically possible to not do anything and alter bone quality. To my knowledge, none of our drugs do that. And it's conceivable that we could just reduce falls risk without changing the bone. So this is up here is where our drugs are at. Which drug? The BHOF guidance doesn't really speak to that. This is the ACE guidance, American Association of Clinical Endocrinologists. They basically say you could use raloxifene or ibandronate, in that all these do is reduce vertebral fractures. They recommend our standard anti-resorbers, lendronate, DMAB, borsedronate, zoledronate in people with high fracture risk, or the parenteral agents if you're at very high fracture risk. And they went on, I think, to do a pretty good job of helping us define what very high fracture risk is. And the easiest ones to remember, I think, are right here: recent fracture, low T-score less than -3, high falls risk or history of injurious falls, and then an MOF probability greater than 30%. And for that, they recommend anabolics. Why do they recommend anabolics for people at very high risk? I'm not going to go through these studies in any detail, but the gist of it is that when you compare the bone anabolics, whether it's teriparatide or romosozumab versus the anti-resorbers, the anabolics win. And as a result, expert opinion is saying we suggest use anabolics first, followed by potent anti-resorbers. Now, I do want to share with you a caveat about the current US treatment recommendations. And that is that we're treating way different patients from a fracture risk standpoint, and also make you aware that a minuscule change in femoral neck BMD of about 0.012 grams per square centimeters will take your patient from -2.3 osteopenia to -2.5. And that's certainly less than the least significant change of our bone densitometer. So moving across this line in the sand is exceptionally arbitrary. And even more important is that the fracture risk of patients is radically different. And so this is a white female, 150 pounds, 5'5", no additional clinical risk factors. She's got a T-score of -2.5. Treat per our most recent guidelines. If she happens to be 50, she has a 7% 10-year risk for fracture. 60, she has a 12%. And it's not until she's 80 years old that she reaches the 20% threshold that VHOF says treat if you have osteopenia. So I think it's okay to treat at -2.5 if you wish, and that's certainly the guidance, but be aware that you're treating people at radically different fracture risks, and we're treating them to reduce fracture risk. My bias that Osteoporosis Canada has it right. I'm not going to go through these guidance at all, other than to focus down here. They basically said if your MORF risk is greater than 20%, treat. If it's less than 10%, don't treat. And if it's between 10 and 20, image the spine to see if you've got an occult vertebral fracture, and if you do, treat. So then we're talking about drugs. And when we think about drugs, we need to consider the risks versus the benefits. And the benefit is right there, maintained independence by reducing fractures. Yes, it reduces mortality. As my patient that I saw on Wednesday told me, we all know we're going to die. I'm concerned about quality of life. That's what we need to be emphasizing. The risks that our patients are really concerned about are ONJ and AFF, osteonecrosis of the jaw and atypical femur fracture. Very briefly, this is what ONJ looks like. It's exposed bone that doesn't heal if you've been exposed to an anti-resorber in the absence of radiation to the head. The incidence in osteoporotic patients with osteoporosis treatment doses is exceptionally low. It's on the order of getting hit by lightning. But all of our patients will be cautioned about this by their dentists. This is a zebra. This is not. The atypical femur fracture, this does occur. The best data that I'm aware of comes out of Kaiser, and it documents this increasing risk of atypical femur fracture with duration of bisphosphonate therapy with a fairly robust cutoff somewhere here around 4 to 6 years of bisphosphonate therapy, such that at the end of the day, the risk of AFF is about 1 in 1,000. That is not rare. Our patients have heard about somebody who has had this and they're scared about it. And therefore that gets into how long should we be treating? And this is the most recent guidance. It's from ASBMR and it's also from VHOF. And this decision tree basically down here says treat up to 10 years. And almost everybody that we start treatment on ends up being at high risk. They've got a T-score less than 2.5, or they've had other fractures. So it's in essence a de facto 10-year risk or 10-year treatment. And the data supporting that are really not strong. This was recently reviewed, or was recently reviewed by Osteoporosis Canada. They took an incredibly rigorous process using the grade approach, and they will be coming forward with guidance regarding duration of therapy. I just received an email last night that the OC guidelines are being submitted today for publication. So this is going to be out there soon. So It's possible, I think, to simplify guidance. It's my bias that the osteoporosis field should learn from others. And this was a wonderful consensus statement on menopausal hormone therapy by the International Menopause Society. And I don't know firsthand what happened, but it sounded to me like they had about 6 folks sit around a table and say, hey, can we come up with consensus points to help our providers? And if you can find something more controversial than menopausal hormone therapy, I don't know what it is. But they did. And their goal was to produce a short document in bullet point style containing only points of consensus. So we did that. There was a group of 4 of us from the osteoporosis clinic, Karen Hansen, Elaine Pelley, Vidushi Sood, and myself. And we said, can we produce a short document in bullet point form containing only points of consensus? And we did. And that's available now on Box at wisc.edu. I was just speaking with Dr. Schnapp about how can we get that out there in an easier way to access. But in fact, it fits on 1 page. And so to very briefly go through what we thought, it says, hey, measure bone density. If you're female over 65, male over 70, or if you're over 50 with multiple risk factors. So think about it, get a BMD. Use the diagnosis of clinical osteoporosis, as I mentioned before. Recognize that not everybody with a T-score of negative 2.5 needs drug because their fracture risk is low. Optimize calcium, optimize D, think about falls. Offer drug therapy based on major osteoporotic fracture risk. Recommend bisphosphonates as first-line therapy. They're cheap, they're easy. Plan to treat for 3 to 5 years, not 10. Let our patients know that we are going to stop therapy after 3 to 5 years. When you stop, get a new BMD, and then repeat it in 2 years. And if the BMD stays stable, you can continue the holiday. If the BMD declines, resume therapy for another 3 years. But recognize that there are people at very high risk. So if you've had more than 2 prior fractures, your T-score is below -3, or your MOF is greater than 30, recommend anabolic therapy or consultation with one of the bone docs. And finally, if you're not receiving drugs, repeat a DEXA based on the MOF risk. We don't need to be repeating DEXAs every year or every 2 years in people with normal BMD. So if their MOF risk is low, you can wait 5 to 10. If it's 10 to 15%, repeat in 5. If it's greater than 15, repeat in 3. Obviously, this requires clinical judgment because clinical conditions change. Patients develop an inflammatory disease, get put on glucocorticoid therapy. These are guidance. These are recommendations. These are not guidelines. They are not guide dogs. So to summarize, osteoporotic fractures are common and they're bad and they threaten our independence, and we need to be doing a better job. I think the BHOF guidelines are really quite good in that they've now come forward and said independence. That's good. They recommend initiating therapy at -2.5, but remember that fracture risk is why we treat, and it's probably more logical. Diagnose clinical osteoporosis by prior fracture, T-score, or elevated fracture risk. Start with the non-drug approaches. Calcium and D, recommend bone drugs based upon elevated fracture risk. Anabolics first if they're high risk, otherwise bisphosphonates for 3 to 5. And I thank you.
Great, a wonderful summary, and I really like the pragmatic approach in the reliance on sort of lifestyle modifications. One thing I wanted to ask when you talked about fall risk reduction is, do you incorporate a home visit to your patients to look for opportunities for falling?
That's a great question. Historically, we did. That I think has gone by the by. It's I think a good suggestion that we should be thinking about that, because there's obvious things throw rugs, cords, et cetera, et cetera, et cetera. Night lights, yeah, good suggestion.
Okay, so online, so the recommendation for patients with very low vitamin D was to give 6 to 8 weeks of 50,000 units weekly and then use daily D3 supplementation. Has that recommendation changed?
Well, no, good question. That still is the recommendation in the ACE guidelines. It's not based on great data, and it's also not based on physiology. So when if you decide to go to the nude beach and lay on the beach all day and bake and create your own vitamin D, you're probably only going to make about 10,000 international units. And when we go with these whopping 50,000 unit doses, we actually upregulate the 24-hydroxylase. So we are increasing vitamin D degradation. So in essence, we're working against ourselves. And so going with 5 to 10,000 IUs of vitamin D3 daily makes more physiologic sense, and it's probably the way to go, and almost never is correcting a low vitamin D level a crisis. So I think 5 to 10,000 IUs a day is the way to go, rather than the 50,000, and certainly not the ergocalciferol approach.
Next question. So an otherwise healthy 44-year-old woman, premenopausal, is going for a run, trips, falls on an outstretched arm, gets a fracture, an ulnar fracture. Workup reveals normal bone density. Does she meet the criteria for having clinical osteoporosis?
Before age 50 and premenopausal, I think is a not well-defined category. I would be reluctant to give a 44-year-old woman the diagnosis of clinical osteoporosis because she's premenopausal. I do think it would be reasonable to say, are you vitamin D deficient? And fortunately, in the UW system, she would also get a trabecular bone score. And so if her TBS is awful, horrible, terrible, and she's had a distal radius fracture, I think that would push one to look for less common things like celiac disease, for example.
Okay, so what does height loss mean if it's measured accurately in the absence of any vertebral fractures?
First define that there's an absence of vertebral fracture, but height loss is really common. I'm not as tall as I used to was, and it's not because of vertebral fractures, it's because my discs are not as plump as they were at age 25. So it's degenerative disc disease.
So from Dr. Trowbridge, biphosphonates and statins are two of the most vilified medicines in the media and a tough sell in primary care. Do you have suggestions on how to encourage uptake by our patients?
Yeah, I think that's a great question. And I'm hopeful that this guidance that we came forward with will help with that. And the approach that I take is, yeah, that happens, but it's rare, and it's exceptionally rare within 3 years to have the bad consequences. And I have a plan, and I'm going to treat you for 3 years. I'm not putting you on this drug and having you on it for the rest of your life. We're going to stop, and we're going to monitor you. And if your bone density stays stable, I'm not going to give you more drugs until your bone density starts declining. I think that is something that, at least my personal anecdotal experience is, that does resonate with patients. I'm not putting you on this drug forever.
Any data on the timing of when you start a pharmacological treatment in a naive patient with a recent fracture?
Oh, okay. That one's easier. I thought you were going to ask when we start at age 40 or 50. There's this noise out there that bisphosphonates impair fracture healing, and that's noise. There are orthopedic surgeons who still believe that. I think our ortho folks are getting away from that concern as a group. But the data just do not support that anti-resorbers cause non-union or failure of hardware. And in fact, bisphosphonates after hardware implantation reduce the likelihood of subsequent need for revision or other complications.
So do whatever you need to do in the OR. et
Well,
cetera,
yeah,
then-
and
then
you know,
start
it's,
treatment.
I guess, we're not going to be treating people with bisphosphonates in the hospital after their hip fracture. You know, the easy thing to do would be to say we're going to give everybody zoledronate in the hospital. The problem with that is about 4 out of 10 bisphosphonate naive patients get the acute phase reaction due to release of cytokines from a class of white blood cells caused by the bisphosphonate. And giving a drug that causes a fever in the hospital post-operatively is a bad idea. So that's not going to happen. And also pretending that we're going to give a bisphosphonate to our patients that are going to the nursing home also isn't going to happen. So they need to be given first thing in the morning orally on an empty stomach with a full glass of water in patients that don't lay down. Well, 7 a.m. in the nursing home is shift change, and this just is not going to happen. So we're going to get oral bisphosphonates crushed in with applesauce, which is administering none of it. So I think that the concept of treating immediately after the fracture is one that just doesn't translate into the clinical real world.
And then the final question, for time's sake, from Dr. Jagru, our favorite stone doctor. Any use for checking and managing urine calcium loss to monitor bone health?
Yeah, great question, Roy. The endocrinology world is enamored with 24-hour urinary calcium. As a geriatrician, I've become convinced that my patients pee in the jug once and fill it up with tap water. But I think if you can get a reliable urinary calcium, that is part of the workup to make sure you don't have idiopathic hypercalciuria or unappreciated calcium malabsorption problems.
Great. And for time's sake, we're going to conclude today. Thank you again for really, and I will echo Betsy's comment, a fantastic presentation and a multi-disciplinary approach to addressing bone fractures and preventing bone fractures in our patient population. So thank you again, and we'll see you all next week. Thank you. It was great. And it was